In the name of God, dear member of the chair, ladies and gentlemen, I am so grateful to be invited to this nice congress, and this is an honor to be among with you eminent people. I'm so happy to visit this beautiful city and country. Let me briefly introduce my cardiovascular center, Rajaei Cardiovascular Medical and Research Center. Very briefly, I want to introduce. Our center is one of the large heart center in Asia, maybe, designed as an H in an area of 110,000 square meters. This hospital was built in 1972, and at the moment has 600 active beds for only pediatric and adult heart patients. The center has over 2,000 staff, more than 100 full-time medical faculty members, include 15 cardiovascular surgeons, over 200 resident specialist fellow and subspecialist fellow in various cardiovascular disciplines. As you can see, we have a specialty and subspecialty residency in cardiology, nuclear medicine, pediatric cardiology, and cardiac surgery subspecialty for 3 years after finishing general surgery for cardiac surgery. And we have this fellowship, as you can see, interventional adult cardiology, interventional pediatric cardiology, electrophysiology fellowship, echocardiography fellowship, heart failure and transplant fellowship, adult congenital heart disease fellowship, and congenital heart disease surgery fellowship, or pediatric cardiac surgery fellowship for 18 months. And cardiac anesthesia fellowship. Our fellowship is 18 months. Also, the center has 13 operating rooms, 5 rooms cath lab for adult cath lab procedure, 2 rooms for pediatric interventional procedure, and 4 rooms for electrophysiology study. On average and on daily basis, there are 70 hospitalization, 20 surgical operation, cardiac surgery, 80 cath lab procedure, and 40 electrophysiology study. Due to lack of time, I would run quickly the slide. Adult, pediatric angiography ward, electrophysiology and pacemaker, paraclinic ward, managerial standards, and total inpatient, total hospitalization in 2017 in a glance, about 26,000 patients totally with surgical and internal. Cardiac surgery in 2017, patient base. We have about 6,000 cardiac surgery in 2017, about 4,000 for adult and 1,500 for pediatric. Pediatric cardiac surgery, you can see variety of number of cardiac surgery in 2017. We had particular pediatric cardiac transplantation. We had 36 cardiac transplantation for children in last year. And interventional cardiology, cardiac electrophysiology, pediatric cardiac electrophysiology, and echocardiography. We had 30,000 echo for pediatric cardiac patients in last year. And my second speech about arterial switch operation, techniques and modification. I want to just review. First of all, I would like to send my best regard to those who I have learned from through the years. Among many, I would like to mention a few. Professor Pascal Vohe and Professor Reiske in Necker Hospital, Paris. Professor M. Rebelli in Marie-Lalonde Hospital. Professor Del Nido in Boston Children's Hospital, Harvard. And David Anderson, Professor David Anderson in Guy's and St. Thomas Hospital, London. And Setia Babula in Royal Brompton Hospital, London, and Professor Joseph Deirani in Mayo Clinic in Rochester, United States. They let me have a chance to be with them for learning more. And Professor Lacour, who I have used and learned his wonderful book titled Surgery of Conotruncal Anomaly. As you know better than me, Jayton in Brazil achieved a major breakthrough in 1917, with the first success of arterial switch operation, Jayton procedure. An important technique modification of original Jayton procedure was demonstrated by Lecomte that transfer pulmonary artery trunk to in front of aorta. The matter was resolved with Radley Smith and Jacob in London, Coeur in Holland, and Castaneda in Boston with their colleagues, demonstrated feasibility and safety of repair of simple TGA in the first few days of life by an arterial switch operation. TGA is one of the most common cyanotic defects in newborn. The arterial switch operation has become the standard operation for TGA. Most technique problems raised by complex coronary artery pattern and by associated cardiac lesion have found adapted solution. There are some classification for coronary artery pattern: Jacob Radley Smith classification, Lydon classification, Marie-Lalonde classification, which is based on the course of coronary artery more than on their origin. As you can see this slide from Coeur. Left main is originated from left posterior facing sinus, sinus 1, and right coronary artery is originated from right sinus, posterior facing sinus, sinus 2. This is one of the classification. But I would prefer this classification, Marie-Lalonde classification, which is based on their course in addition to origin of coronary. We have normal course, 2 ostia, looping course, 2 ostia, posterior looping course, double looping course, anterior looping course, and intramural course, 2 ostia, and single ostium with different courses. You see a normal course, 2 ostia, left main is originated from left sinus, and right coronary artery is originated from right sinus. Looping course, in the top you can see LCX is originated from right sinus, and its course is posterior, retropulmonary. And middle, we can see double looping. Left main is originated from right sinus and posterior looping, and right coronary is originated from left sinus and looping anteriorly. And this is double looping, and this is anterior looping of LAD is originated from RCA. Left intramural course, challenging course, challenging surgery. Left ostium is in right sinus with intramural course. It is more frequent than this right ostium in the left sinus and intramural course. And 2 ostia above posterior commissure with intramural course. Single ostium with miscellaneous course. In the top, all 3 coronary are originated from right sinus with posterior looping of left main, with posterior looping of LCX, and anterior looping of LAD, with anterior looping of left main. And single ostium, all 3 coronary are originated from left sinus with anterior looping of LAD with single ostium, RCA, sorry, with anterior looping of RCA with single ostium left, single left ostium. Single ostium intramural course, it is challenging. 1 coronary is originated from above posterior commissure and intramural course. A preoperative checklist for arterial switch operation. Coronary anatomy defining, simple or complex coronary. Is there any significant VSD? Is there any aortic arc obstruction? Is there any LVOT obstruction? Absence of intramural cranial bleeding? Absence of ongoing fetal-maternal infection? This slide shows site of cannulation. The aorta is cannulated as high as possible near innominate artery, and the SVC, IVC are cannulated directly. But I would prefer this method. I would prefer to cannulate SVC indirectly from right atrial appendage to SVC to prevent SVC stenosis and supravena cava syndrome after operation. Harvesting pericardium, fresh pericardium, control of PDA, ligation of PDA, and transection of PDA. The division of PDA or ductus arteriosus requires an accurate technique. Any tear or needle puncture of ductal wall proximal to ligation should be avoided, as a tear of origin of ductus arteriosus is difficult to control. Additional direct suturing usually worsens the bleeding or may create an stenosis-like coarctation. Serious bleeding at this stage is better controlled under circulatory arrest. Cannulation, as I told you before. In my opinion, the transection of artery, great artery, is a crucial step of arterial switch operation. This slide shows a standard method for repair. The aorta is transected just above sinotubular junction, a few millimeters above sinotubular junction. And the pulmonary trunk is transected proximal its bifurcation. The objective is to reduce length of the aorta that will stand behind PA following the Lecomte maneuver. The aorta is divided in high position at middle point between clamp and aortic annulus, and PA trunk is transected in low position, few millimeters above commissure. I would prefer to transect aorta as high as possible. I think 2/3 above annulus and 1/3 under innominate artery or cross clamp is better than middle or low incision. We want to have a long neopulmonary and short neo-aorta. And I would prefer to transect pulmonary in as low as possible. Lecomte maneuver is then performed. PA branches are fully dissected until lobar branches are clearly seen. Following a high division of aorta and low division of PA, the posterior neo-aorta length is reduced and anterior neopulmonary artery is long. The pulmonary bifurcation should be free-floating on the aorta. As I told you, after Lecomte maneuver, we have long neopulmonary in front of short neo-aorta. For aortic root stabilization, I would prefer to repair of posteriorly of neo-aorta partially. The harvesting of coronary button is an important step as well. To allow safe button anastomosis, it is crucial to take the largest possible button, removing nearly the entire sinus of valsalva. Coronary trunk are mobilized on a few millimeters and generously in the case of looping courses. There are some evidence that neo-aortic root is enlarging with time after arterial switch operation. So the reimplantation of coronary button should avoid increasing the aortic root diameter, which is already large in TGA. So we avoid using the trapdoor incision that increases the root diameter. Instead, we resect a piece of neo-aortic wall and place the button in a space created. Some surgeons are using the technique of closed aorta, with first reconstructing the aorta and then checking the location of button. That is technique also avoid enlarging the aortic root. The left coronary button is placed in low position. Harvesting the large coronary button, rectangular resection, and put left coronary in low position, no trapdoor technique. The right coronary button is placed in higher position. The bottom of right button is placed in right aortic root sinus as lateral as possible. In order to correct the diameter mismatch between neo-aortic root and distal aorta, the superior part of button is included into the ascending aorta. The aortic anastomosis should be permanently controlled and adjusted so that the anterior commissure remains exactly at 6 o'clock. The right button will be placed higher in case of posterior and double looping courses. Limited wall resection, distal aortic anastomosis and lateral incision of aorta, and right button enlarged distal aorta and can solve diameter mismatch between neo-aorta and ascending aorta. Some surgeons prefer to put both coronary in low position and in the both sinus. Three special features can be seen in all coronary patterns: ostium next to a commissure, early infundibular branch, and commissural malalignment. Sometimes one ostium is located near and next to posterior commissure. In order to take a safe and large button, the commissure is taken down and will be reimplanted later on pericardial patch. When there is early infundibular branch, when it is large, this branch is dissected to release the tension. When it is small, this infundibular branch could be divided. Kinking of left coronary may not be obvious by inspection and could be only suspected on EKG changes or hemodynamic instability. Commissural malalignment, a very challenging case. When there is significant commissural malalignment, you can see this commissure and this commissure. This is difficulty to transfer coronary, particularly when there is anterior looping. Prior to transferring the coronary, the distal ascending aorta and pulmonary artery trunk are rotated in opposite direction in order to realign the anterior and posterior commissure. We should realign commissures and then transfer to coronary, right button in high position, left button in low position. We can use trapdoor. Pulmonary trunk reconstruction, it is safer to perform the reconstruction of PA trunk with aorta cross clamp. And coronary complex transfer, looping. The posterior looping is associated with risk of kinking, and anterior looping with risk of stretching. As a rule, when there is posterior looping vessel, the right button needs to be reimplanted in high position to prevent the kinking of posterior vessel, L6 or left main. When there is an anterior looping vessel, RCA, it should be dissected extensively to prevent stretching the coronary. Some surgeons are using trapdoor technique. I would prefer to perform trapdoor technique when I have anterior looping courses. Posterior looping of two ostia, the circumflex is dissected posteriorly from the PA trunk and right button is placed in high position and included in the aortic anastomosis. Some surgeons prefer to perform trapdoor technique when there is a second most common coronary pattern, 1L2RCX. A little, you gave me, okay. Sorry. Some people use trapdoor technique for posterior looping, and when we have anterior looping, I would prefer to perform trapdoor technique. And the anterior looping vessel always RCA is extensively diseased and dissected free from the aorta, as well the posterior looping vessel, either the circumflex or the left main trunk is dissected free from PA trunk. Right button is placed in high position and left button is placed in low position. Some surgeons are using a trapdoor in left button. When we have side-by-side great artery vein tossing being, after Lecombe maneuver, reconstruction of pulmonary bifurcation can compress right coronary that is looping anteriorly. And I would prefer not to perform Lecombe maneuver and repair of neopulmonary with RPA. Single ostium, double looping, I run quickly. Intramural course, very challenging case. Coronary transfer with intramural course challenging. First, the posterior commissure is totally detached. The intramural course is evaluated using a coronary probe. It can be extremely long, measuring more than 20 millimeters. The two ostia are harvested in block. If we have enough space between two coronary, we can create two button and transfer two button coronary. Single ostium coronary, when there is single ostium coronary, extensive dissection of looping coronary trunk is essential. The right button is transferred in high position. Trapdoor is useful. Single left coronary is reimplanted in low position. Creating two button is the most appealing technique. And when we don't have enough space between two coronary, we can use a piece of pericardial patch to create a hood for repairing of single ostium coronary. Thank you for your attention.